Blood cultures for bacteria and yeast are among the most clinically important and high-volume tests performed by clinical microbiology labs. Because these cultures are so important to clinical care, we want to make sure that blood cultures are performed as quickly and accurately as possible, and that they're ordered, collected, and utilized appropriately. We're going to talk about two recent papers on this critical test. The first is about diagnostic stewardship for improving utilization of blood cultures, and the second is about reporting blood culture results more quickly. We'll put the links to both articles in the show notes. Some of the questions we'll discuss include, first, what steps can be taken to reduce the number of inappropriate blood cultures ordered in non-neutropenic adult patients? And second, can the final results of blood cultures be reported earlier than the canonical 5 days? Welcome to Editors in Conversation. This episode is brought to you by the Journal of Clinical Microbiology, available at jcm.asm.org and on Twitter @jclinmicro. I'm your host, JCM Editor-in-Chief Alex McAdam. This podcast is supported by the American Society for Microbiology, which publishes JCM. I'm joined by two expert guests. Dr. Valeria Fabre is a specialist in infectious diseases and the Associate Medical Director of the Antimicrobial Stewardship Program and an Associate Hospital Epidemiologist at the Johns Hopkins Hospital. She's also an Assistant Professor of Medicine at the Johns Hopkins University School of Medicine. Valeria, welcome, and thank you for coming on the podcast.
Pleasure to be here.
We're also joined by Dr. Eric Ransom. Dr. Ransom is a fellow in medical and public health microbiology in the Department of Pathology and Immunology at Washington University School of Medicine in St. Louis. Welcome, Eric, and thanks for joining us.
Thank you for having me, Alex.
The first paper we're going to talk about is titled, A Diagnostic Stewardship Intervention to Improve Blood Culture Use Among Adult Non-Neutropenic Inpatients, the Distribute Study, by Dr. Fabre and her colleagues, published in the October 2020 issue of JCM. Valeria, can you tell us first what problem or issue with blood cultures you addressed in your study?
Sure. We conducted this study because we wanted to improve blood culture ordering practices in the hospital setting. As you said, blood cultures are one of the most common microbiologic tests that patients undergo in the hospital, and this excess of blood cultures is not free of consequences. This could mean for a patient that there will be unnecessary antibiotics related to blood culture contamination, which comes, as you can expect, the more blood cultures you order, the more likely you may get a false positive result. This was also may result in delays in hospital discharge because the patient will undergo more blood cultures to clarify whether the initial blood culture was true bacteremia or not. And there's many consequences from that excess of blood cultures. And there's been several studies that actually have shown and discussed this issue of unnecessary blood cultures, but really there's been very little in terms of interventions to reduce blood cultures in the adult population. So this was the focus of our study.
Thank you. What was the basic design of the study before we get into the intervention itself?
Sure. So this was a before and after study. So we collected blood culture data 18 months prior to starting the intervention. That was our baseline data. And then we collected blood culture data for 12 months after the intervention was implemented, and we did that or for our intervention units, which was the medical ICU and 5 medicine units at the Johns Hopkins Hospital, and also for reference, we collected data from surgical units, which served as control as they did not participate of the intervention.
Were all the data collected retrospectively after the intervention had been done and then that study period had passed?
So for the baseline period, it was retrospective. For the data following the intervention, that was prospectively collected.
Got it. Thank you. So tell us about the intervention itself. What did you do to guide clinical decision-making for ordering blood cultures?
Yeah, so actually the intervention was informed by prior work that we had done at the hospital. We had been talking to frontline providers for some time, and it had become clear that there was an opportunity for improving or for developing more specific guidance on when to order blood cultures. So when we talk to providers about how do they think about blood cultures, we realize that there may be some recommendations here and there in different guidelines, but that information is not necessarily consolidated in one place. And so we put together an algorithm that could be used at the point of care, that was user-friendly, and that was based on evidence, and it helped the providers think through whether a blood culture was needed or not. So we developed this tool, which we shared with ordering providers. We explained the content of the algorithm. We developed some educational material that we delivered in person regarding best practices. And when we kicked off the intervention, so we disseminated the algorithm, we were reviewing cases from the participating units, and we were providing feedback about some specific cases and what were the reasons for us calling those blood cultures inappropriate, so they could think through the cases and not make the same mistakes, or change their practices for future cases. And we also provided feedback about the blood culture order rates and the trend as they were moving into the intervention. So it was basically the algorithm, making sure that people understood the content of the algorithm, and then providing this additional feedback on cases that I think people really valued, because they were able to critically think through different cases.
One of the things that's always seemed to me to be hardest about this kind of educational intervention is making sure that the frequently rotating staff are aware of it as new people come onto service. How did you make sure that they were on board and that you reached as many people as possible?
Absolutely. And as you can imagine, this could be a particular challenge for a big institution. And so it wasn't one educational session, it was multiple. We used different venues, from the before rounds in the ICU to the big conference for house staff, and we also came to the different medical ICU and medicine staff meetings, so we could also reach to attendings. We also reached out to mid-level practitioners. So that phase, I would say, it was very intense, and it was multiple sessions that we did to make sure that everyone was being captured. And actually, I would say that some people got really interested, because many were not aware of what they were doing wrong, or many were not aware of the blood culture quality indicators that the microlab monitors of, they really embraced the initiative, and they've started their own WhatsApp group where they disseminate, the algorithm, and they took on their own, especially the senior residents, to train the new people coming in, which was really cool, because it's hard to maintain an intervention, and the fact that other people champion the efforts with you make it so that the intervention is accepted more broadly.
Yeah, having those local champions always seems to be very important in this kind of thing. And then, if I understood correctly, you were also, or your team was also contacting people and saying, "We noticed you sent this blood culture. It doesn't really fit with what we planned in the algorithm. Let's talk about it." Do I have that piece of it correct?
Yes, exactly. So I would summarize my case review in an email, because that's nice for them to have as a reference. And I would provide very specific examples. And I would provide, if needed, some references as to why there was really no benefit on getting blood cultures. And we would come to the unit intermittently to make sure that if there were questions, we could address them, because we understood that for clinicians, it's hard to make a clinical diagnosis of bacteremia, because the signs and symptoms are non-specific, and so we needed to be able to guide them in a different way, because what we see, and I think this is a problem in many other hospitals, is this issue of fan culture. So a patient develops a new clinical sign, commonly a fever, but it could be a leukocytosis, and very frequently the response to that is we'll send cultures, for all sorts of cultures. And so we really try to change that and say, well, you have to think really hard. What do you think is going on with a patient? And try to, walk them through, by systems. Is it pulmonary? Is it this? And then once they are able to put the information together into, I think this is more a UTI, or I think this is more a pulmonary infection, then it's easier for them to say, well, if I think the patient is having pyelonephritis, then I know that, this is my chance of, the blood culture helping me to find the bacteremia. If it's a patient who's having a diabetic foot infection, then I know that then the blood cultures are not going to help me. And that's what the algorithm has. It walks the ordering provider through the more common infectious syndromes, and which ones are the ones where the blood cultures are going to impact management because they are more likely to be positive. And then the ones where we know that almost always are negative, and there's no value on sending that blood culture, which, as when we started the conversation, we are risking of having a false positive result and having all those consequences.
Got it.
And
Thank you. Yeah, please.
the other aspect that we worked on was the issue of repeat blood cultures, because when we had done the survey, which actually was done to kind of assess what was the gap knowledge in terms of blood cultures, it became apparent that the general perception was that if there is a positive blood culture, there must be a follow-up blood culture to make sure that whatever was found on the first time, it's no longer present, and that's not right. So we wanted to put education on that side of blood cultures too. So those are the two pathways in the algorithm. Either you're ordering blood cultures because you had a positive one and you want to document clearance, and we try to specify in which circumstances that was needed, and the many others where it's not. And then the other pathway is I'm ordering blood cultures for the first time, those initial blood cultures, which would be when the patient comes in, or it could be the patient has been here, but now there's a new clinical event.
Thank you. That's great. That's great. All right. So we've got the intervention, and now it's time to start getting some data. So what were the primary and secondary outcomes that you looked at?
So the primary outcome of the study was overall blood culture orders per 100 patient days. And the secondary outcomes included single or solitary or lonely blood cultures, blood culture positivity, and blood culture inappropriateness. And we also included what we call balancing metrics, which were readmission, mortality, and compliance with the blood culture component of the SEP1 measure. This would be our safety metrics to make sure that the intervention is not having an impact on patient safety. And for those who have not heard of the SEP1, this is a CMS quality initiative that measures how well hospitals do with the sepsis bundle, and it has, among other criteria, a blood culture component in which obviously you have to get timely blood cultures. So the concern was that because we were trying to reduce blood cultures, that it could have a negative impact on the SEP1 measure.
That makes sense. So what effect did the intervention have on the blood culture utilization rates?
So the intervention did work. Blood cultures were reduced in a different way. We saw an 18% reduction in the medical ICU and a greater reduction in the medicine units. As I mentioned earlier, we included 5 medicine units, and we looked individually. And we also reported the data as a mean in aggregate. And the reduction was 30% when we combined all the units together. But again, it was significant when we looked at them independently. It's interesting that we saw the reduction in the medicine units was quite steady over time, where in the medical ICU we did see more variation in terms of the reduction.
What do you think was the explanation for that variation in the medical ICU?
I think it may have to do with the shifts, and there's quicker turnaround of staff in the medical ICU, and I think it may have to do also with the type of patients that the medical ICU sees, where there could be more. We were looking at it by month, so the patients could change quite a bit from one month to the other.
Got it. And it seems to me to be an enormous decrease in the number of blood cultures. 18% to 30% reductions. It seems enormous to me. And Eric is nodding also. Yeah. Did you expect to see such a large effect?
Well, we didn't, but when we started it, we knew that there was. No one is seeing it, but if I had to show you, like today, how that graph looks in terms of blood culture use at our institution, it is quite high. And so we knew that we were starting with a lot of excess, and it wasn't going to be hard to see an important reduction, right? Because we were, we started too high. And I have to say that when you looked in the literature, there's reports from Israel and Europe and the US, and the rates are vary quite a lot. And there are other institutions that have much higher use than ours, and ours is already high. So I think there's definitely a lot of room for improvement. We did want to get a sense of how much inappropriateness there was, and we found that about 40% of blood cultures in the medical ICU could have been avoided, and up to half of the blood cultures in the medicine units could have been avoided. This is based on our chart review, which could be an overestimation because when you're looking at a chart, you don't necessarily have all the information that the primary team has when they are seeing the patients. But it has been discussed in multiple papers and guidelines and forums that we order too many blood cultures. So
When you say that you could reduce the number of blood cultures by 40 to 50% based on chart review, was that chart review conducted before or after the intervention?
It was before the intervention. We didn't see a significant impact on appropriateness with the intervention. Now, that's a much harder metric, and obviously we could not review the thousands of patients of cases that we included, and we were doing that in a much smaller sample. And it was kind of exploratory because it hasn't really been described. It hasn't really been characterized how much inappropriateness there is. It's always been the attention to we probably order too many because the blood culture positivity rate it's below 10%, and in some places it's below 5%. So clearly you're some of that it's because you're ordering it in people who are not likely to have bacteremia, right?
Mm-hmm. And I think we started to get into it a little bit, but can you tell us about the secondary outcomes that you were looking at?
Sure. So again, even though it wasn't the primary focus of the project, we had seen an opportunity to improve how blood cultures were being obtained, and I'm specifically referring to the two sets versus the single set. This is something that the medical ICUs usually tend to have or be a challenge because of the type of patients they have. They're very edematous and it's hard to get access, and so it's more likely that you in the ICU, it happened outside of the ICU, even though we were trying to fix it more in the ICU. Blood culture positivity went up, and this has not been established, but the idea is that blood culture positivity should reflect your good practices. So if you're ordering them appropriately, your blood culture positivity should go up. As I said, we did not see a significant impact on appropriateness. And then in terms of the safety measures, there was no impact on the metrics that we looked at, and those were similar between patients who got blood cultures and patients who did not get blood cultures. So indicating that it was safe to do so.
We lost you there for a second, but I think we got the important points. Eric, what do you take away from Valeria's study? How do you think it can inform our practice in the clinical microbiology laboratory?
Yeah, well, first of all, really impressive work that really highlights the power of clinician education in diagnostic stewardship. It's a great reminder of just how much of an impact you can have without messing with the analytical performances in the lab, and still coming out, working with key stakeholders in your institution to really get kind of the best bang for your buck. Kudos to you all for the work. And really, after seeing it, it makes me think, what parts of these can we implement? I think not only in the blood culture component, which obviously you showed, but just revisiting some of these other cultures in the clinical microbiology laboratory. I think you can apply these same principles widely in the lab. And I just thank you. Great work.
Oh, thank you, Eric. And yes, this is something that is not in the paper, but I think something else that the intervention achieved was, as you were saying, kind of like closing the gap between the lab and the frontline providers and bring the bench to the bed, because clinicians were like, whoa, we didn't know that one set wasn't optimal. We thought that it was less painful for the patient, so we're like, let's get only one set. And so many misconceptions and things that we needed to work on.
Thank you. I agree. I think it's an excellent paper, and it really illustrates, as you both said, the importance of the laboratory working closely with stewardship programs and the successes that can come from that. I want to turn now to the second paper that we're going to talk about, and that is evaluation of optimal blood culture incubation time to maximize clinically relevant results from a contemporary blood culture instrument and media system. And that was by Dr. Ransom and his colleagues, and it's published in the current issue, the March issue of JCM. Eric, you looked at how long blood cultures should be incubated before issuing a final negative report. In my 25 years as a clinical microbiologist, the answer to that question has always been 5 days. Can you tell us the history? What led us to 5 days being the usual incubation time for blood cultures?
Yeah, absolutely. So the current 5-day cutoff that we are all so familiar with really kind of has a fascinating history. If you look back in the literature, early 1980s or even before, you see all sorts of recommendations from publications, 5 days, 7 days, 10 days, 14, even 20 or longer for some microbes. But as the field starts implementing more automated blood culture systems, and they start coming into the lab, you see all this interest in reducing the time of incubation. And then there becomes a surge of just great work coming out of the field, favoring a shortened incubation time. And then it kind of settled on 7 days for a while. There's a few different great papers that really encourage the current 5-day, 2 exceptional works by Dr. Wilson from Duke and Dr. Hardy from Rochester. They clearly demonstrated a 5-day incubation was sufficient from kind of the 7 days at that time. And frankly, they use a lot of the same analyses back then as we use in our current publication. And so they gave us a great framework to work with. And then after the late 1990s, early 2000s, 5 days becomes the standard. New equipment comes out. It's kind of recommended as a baseline. You have governing bodies or institutions really recommending as the 5-day be a standard. And that's what we're all familiar with now.
So you've touched on it, but just can you give us the specific question that you wanted to answer in the study, and how did you go about answering it?
Absolutely. So the specific question was really, what is the clinical impact of blood culture bottles that flag positive after 4 days? And I would like to say I had this epiphany, but honestly, this question really arose from our technologists at the blood culture bench. But before the study started, it was almost weekly. Our technologists would say, why are we working up these cultures that are positive after 4 days, right? A lot of these patients are already discharged. Usually when we grow a positive organism, it's Propionibacterium or now Cutibacterium species. And so who's really acting on these results? Does anyone really care? And, at first you're reassuring these people, absolutely this means a lot. You need to keep doing this. But then we started looking into these patients more, and their suspicions were correct. And so I talked to Dr. Burnham, my mentor. We ended up writing an IRB together just to do a 1-year retrospective review of every blood culture bottle that went through our system. And then we specifically dove into the medical records of all those patients that had positive bottles after 4 days just to see, were they having an impact?
I love that it came from the technical staff in the laboratory. A lot of good questions do. So when you took that retrospective look at the time to positivity for the aerobic and anaerobic blood cultures, what did you find?
Honestly, I was a bit surprised right off the bat with these. The mean time to positivity was pretty close. Aerobic bottles was 20 hours, 22 hours for anaerobic bottles, so only a 2-hour difference. Even looking at the time to achieve 95% of your positive bottles, it took aerobic bottles 54 hours and anaerobic bottles 59 hours. So there's a little difference there, yes, but it wasn't, 10 hours or half a day or a day that I probably would have thought going into this study.
I think I would have guessed more.
Yeah.
Yeah.
So this really led to the conclusion that there's a minimal difference in the time to positivity between aerobic and anaerobic bottles. And, this is the main reason why people think of holding them on longer. Oh, anaerobes grow more slowly. You need to have an extra day or two for those to come up. And so that was the first really big piece of evidence in our study that was just really surprising, and thought, hey, maybe this 4-day may work after all.
So that's the aerobic anaerobic comparison. How do the different species of bacteria differ in the time to positivity in the blood cultures?
This was probably my favorite part of the data analysis, looking at all the different microbes and their growth rates. So for a lot of microbes like Staph aureus, Pseudomonas aeruginosa, they all kind of had this mean time to positivity of about 20 hours. That's about the time that 50% of bottles will go positive. But then you had organisms like E. coli that had a reduced time, 12.3 hours. And then our fastest growing one was actually Streptococcus pneumoniae at 10.6 hours. And the fun fact I like sharing with people is we looked at the outcomes of 200 bottles that grew Strep pneumoniae. And the longest it took any bottle to go positive was 39 hours, which was very surprising to us. And some of the information that came out of this was very useful to our Ph.D. clinicians. I thought, oh, this is useful to know that when there is a positive bottle with Strep pneumoniae, it is in a very short period of time. And then in addition to kind of the microbes we looked at, there's some important patient populations we wanted to focus on, including the pediatric ones that I just mentioned, because sometimes you'll hear pediatric bottles need to be incubated longer.
I hear that a lot.
Right.
Sorry, go on.
And what you'll hear is, you may get 1 ml of blood or 5 mL of blood, and because you're not getting as much blood, you may need a little bit longer for those to flag positive. So this was another area I thought, maybe we do need to hang on to 5 days. But when we looked at the data, the pediatric population compared very well to the adult population, and in different subsets of the data actually performed better than the adults.
So what was the clinical impact of those blood cultures that were positive later than 4 days in that fourth to fifth day period? How important were those positives?
Yeah, great question. So we looked at the outcomes of a little over 158,000 bottles. We found that only 175 flagged positive between 4 and 5 days. So just an overall numbers, pretty low. But then looking at those 175, we really needed to dive into the charts. So we had 2 individuals review the medical records to see how were clinicians responding to these positives. And we found that out of those 175, 160 actually had no impact. And in fact, most of them were specifically recorded in the medical record as contaminants or probable contaminants, and to ignore them. So no change in therapy, nothing of significance. And then the remaining 15 bottles all had impact. But unfortunately, we saw that for several of these, they actually had a negative impact on patients. These were patients that had been discharged because they had negative cultures. And then 4 days later, we notified the clinician. They asked the patient to go see the ED. They asked them to go see their primary care physician. And so we thought, this is unfortunate. We're actually harming some people in these situations financially. And then there are other examples in which we were delaying discharges, where there would be a Propionibacterium species that would flag positive right before they're going to discharge the patient, and then they wait for the lab to identify it. And so there were just some situations that were pretty unfortunate. Now, with that said, there ended up being about 9 bottles in which we said there was a potential positive impact. So that rounds out to about 0.006% of our bottles. A lot of those were narrowing of therapy. We'll never know for sure if it was really necessary or not, but we feel very comfortable saying that 9 bottles conservatively out of a little over 158,000 had an impact.
And whenever we talk about making blood cultures shorter, there's this group of bacteria that comes up, the HACEK group, HACEK. You had relatively small numbers of HACEK in most of the organisms within the HACEK group in the part of the study you've described so far. So you had to take another method to look at those. So tell us a little bit about the HACEK bacteria and how did you look at the time to positivity for those?
Yeah, the HACEK group of organisms, they're a fastidious group of gram-negatives most commonly associated with endocarditis. The acronym stands for Haemophilus, Aggregatibacter, Cardiobacterium, Eikenella, and Kingella. As you mentioned, if you look in most textbooks or reading materials, they'll tell you that an extended incubation is warranted to detect these organisms because they are slow growing. There are reports out there, though, of them not being slow growing, and we thought, well, this is a great opportunity. Certainly, if we're going to reduce it from 5 days to 4 days, people are going to want to know how does this impact your hazics. And as you mentioned, we had a significant number of Haemophilus species. They all grew well within the 4-day time points. We weren't worried about those. But for those others, we either had 1 or 0 isolates in our data set. So we needed to figure out how to analyze this group a little bit differently. So we called up our folks in transfusion medicine that had some expired blood and performed some contrived samples using all of the frozen samples of isolates we've detected in the past in our laboratory. Now, unfortunately, there aren't a lot of these in our laboratory, and they are fastidious, and so it turned out even though we had a pretty decent collection, very few of them survived the freeze-thaw cycle originally. But of all the ones that did survive, we were able to put them on the Virtuo system, and we found that all of them were detected within that 4-day time period. So that made us feel very reassuring. And for people that are wanting an update, we still have detected many more since this publication, and all of them are within the 4 days. So we were very excited to see that these hazics seem to be very easily detected within 4 days, at least in our hands.
So when you wanted to roll this out, how did you present it to the clinical staff?
Yeah,
was there any pushback?
Great question. So we kind of compiled the data. We went and talked to all of our providers. We talked to our ID clinicians, our adult, our pediatrics, shared the data even with other hospitals in our system, some internal medicine and non-internal medicine. Everyone was interested in blood culture bottles. And, you have these conversations, and I think the immediate response to everybody was, you can't reduce it. 5 days is the standard. But then after showcasing the data and walking them through it, everyone was pretty excited about it. They thought, oh, you're right. Even if a bottle takes 4 days to go positive, those organisms usually take another day or even 2 days before they get ID'd. And these clinicians were thinking, 7 days after you order a blood culture, you've moved on with your differential. You've either treated the patient, moved on, the patient's discharged. And so people end up coming around and really enjoying the data and being really excited about it, which I found exciting. And so when we got to finally switch to the 4-day cutoff, people saw the benefits, which was getting those negative cultures 1 day earlier. And now for over 60,000 cultures a year, they're getting results faster. And now everyone's happy about that.
And you've mentioned a couple of times, Eric, that you use the Virtuo blood culture system in your study. Do you think that the findings can be applied to other blood culture systems? Is there anything different about this system in particular?
Great question. As much as I would like to say these findings could be universal, unfortunately, it's really limited to this machine and the Virtuo system. So it has some great advantages. The media works really well. The system also is mostly enclosed. You're not opening drawers or anything in which it's decreasing the temperature. So there's some aspects of the system in which the performance does perform very well. I know there are also additional works out there arguing for shortened incubations on other systems. So I'd certainly encourage our listeners, if you're interested in other blood culture systems, to go see those works where there have been proposals of 4 days for different systems, as well as even 3 days for some.
Got it. And one thing I was struck by when I visited the lab at WashU a few years ago was something you mentioned. I just want to tease it out a little bit. And that is that with this blood culture system, you're not opening the doors, right? So when you load bottles in and when bottles come out, you don't actually open the door and drop the temperature of the entire incubator. And it's sort of appealing to think that that might be a reason why shorter incubation is possible, but hard to know.
Exactly.
Valeria, what do you think would be the clinical consequences to finalizing negative blood cultures in 4 days? What's your response to Eric's study?
Well, I thank Eric for doing this study, and I thank him for being so inclusive and getting the PITS data, and for taking the effort to go through the charts, because that's always very meaningful for us to know those details. I think obviously changing the practice or this practice would be very beneficial for the lab, because Obviously, you could reallocate resources, and that's always desired in any lab. And I think I was thinking about, what we do on our daily practice, and I think, it's only with Staph aureus, with MRSA, that we say we feel comfortable peeling off vancomycin and making, antibiotic switches early during the management of a patient. So I think knowing that if you didn't see anything by day 4, you're not going to see anything, or at least anything meaningful that you should worry about. That's very helpful for the clinician, because we do see, obviously there's variation in practices, and sometimes people really want to wait until there's the cultures are finalized to kind of like close the case and let the patient go, or do the dispo plan. So as Eric discussed it in his paper, I think this could have an impact on dispo planning and patient management.
Thank you. I think it'll be really interesting to see if there's uptake of the shorter incubation and studies on this in other systems. It would be really nice. You two are in luck, because we do have time for a quick game. This game, which I made up in the 10 minutes before we started to record, is called Real Pseudo or Pseudo-Pseudo. There are a lot of species of bacteria that begin with pseudo, with Pseudomonas being the best known. Pseudo has its origin in the Greek for lying or false. I'm going to name 4 organisms with pseudo in their name. Some of them are real, according to the Manual of Clinical Microbiology, and some of them I made up. So the two of you can work together to figure out whether these are real or fake. If you get 3 of them right, you will win awesome bragging rights. So our first one is Pseudocitrobacter anthropi. Real or made up? Pseudocitrobacter anthropi.
I think it's a made up.
All right, let's go with that.
All right, made up. It's a real one.
Oh, sorry, Eric.
Pseudocitrobacter anthropi is a member of the Enterobacterales, which we used to call the Enterobacteriaceae, and it has been isolated from a small number of patients at a military hospital in Pakistan. All right, so you got to get the rest right.
Uh-oh.
Our next one is Pseudospatula discourse.
Definitely made up.
It is made up. This is a fake one.
Good,
Spatula
good.
discourse. I put pseudo in front of spatula discourse. Spatula discourse is, of course, the blue-winged teal, which is a small dabbling duck found throughout much of the country. Recently spotted in Massachusetts, though not by me. I'm a bird watcher. Who would have guessed? All right, our next one. Pseudoanus creca. Pseudoanus creca.
Oh, that's difficult. What do you think? Is it real?
Sounds made up again. I'm so sorry.
It is. It is made up again.
Good.
This is Anus creca, which is the green-winged teal. All right. So you have 2 so far. You have to get this last one right. Pseudochrobactrum asacrolyticum.
Real.
Real.
You say that with such confidence. Do you know it? Have you met this bug?
No, but it sounds very real.
It's got the ring of truth. Well, you are absolutely right. This is real. This is a non-fermenting gram-negative rod, which has been described in case reports of joint and wound infections. Great job. You got 3 out of the 4. You have awesome bragging rights. Tell your friends, tell your family.
Yay.
Thank you, Valeria and Erica, both for discussing these really interesting papers. We will put links to the articles that we discussed on the webpage for the podcast. You can find the Journal of Clinical Microbiology at jcm.asm.org. Thanks for listening.
Thank you so much.
Thanks.